afternoon, everyone. I'd like to welcome you to another episode of Riverside Talk. This topic today is the fight against breast cancer and the progress we have made. Today's speaker will be Dr. Nidhi Sahgal, who is a breast surgeon here at St. John's Riverside Hospital. But before we begin, I would like to acknowledge my team that make these webinars possible. Nancy Anabi, our community liaison. Candace Cousins-Hopkins, my Associate Director of External Affairs, and Jason Latour, our Media Production Manager. Without them, we couldn't be doing these, and so we thank them for getting us live and ready to go. Also, I would like to acknowledge our original partners, the Yonkers Neighborhood Naturally Occurring Retirement Community and the Yonkers Public Library. But I would also like to welcome our new partners in this endeavor, and that is the Ashling Irish Community and Cultural Center, the Department of Veterans Services of the City of Yonkers, Ardsley Parks and Recreation, Ardsley Senior Center, Bronxville Community Center, the City of Yonkers, Community Baptist Church, the Hastings Community Center, the Irvington Community Center, Westchester Jewish Community Services, and Yonkers Pathways to Success. Before I introduce our speaker, I would like to just let every one of our attendees know that if they do have questions for the speaker, we are happy to have you join in the chat, pose them, and at the end of our presentation, I will look at them and ask the questions that are put there, so feel free to do that. And now let me take this moment to introduce our speaker, Dr. Nidhi Sahgal. Dr. Sahgal is a breast surgeon who has been in practice for 22 years in Westchester County. She is board certified in surgery and is a fellow of the American College of Surgeons. Her practice is dedicated exclusively to breast diseases and breast surgery. After general surgery training, she completed a breast surgery fellowship at Stanford University Hospital in California. She is a cancer liaison physician for the American College of Surgeons and a member of the American Society of Breast Surgeons. And we are always pleased to have her. She has been a guest before, but we're very pleased to have her today. And so with that, welcome.
Thank you so much.
Of course. So
wonderful to be here on this important month.
Yes, as we celebrate Breast Cancer Awareness Month. You know, it's funny, we've been doing this a long time. And I think in our little meeting before we did this, we talked a little bit about the fact that, you know, it's kind of interesting that we've all really committed to this breast cancer awareness celebration, and we do education and everyone participates. They wear pink, they do walks, they do all kinds of stuff. But honestly, you know, at a certain point, I actually asked myself, where are we? I mean, are we making an impact? So my first question is, we know there's a lot of things in the news. What are the current statistics for early detection? What are the cure rates? Are we making a dent in that?
Excellent question. You know, you're right. Every month when October comes around, everyone's wearing pink. Everybody's talking about what they're hearing around them in the communities, and everybody's been touched by this disease in some form or the other, I feel. And perhaps I see the gamut of anything from early to late stage breast cancer. And my hope is with October, we can never have data that says, yes, we're doing better because we have October as our Breast Cancer Awareness Month. But I do feel that we know that if we find cancer early, we can cure it and save more lives. That's a known statement. And our hope with October is that women go for their mammograms, women go to the doctors to discuss their risk, discuss their family history, discuss it among their families, among their friends. You know, there's shop talk at nail salons are sometimes one of the best conversations you can have, where you can promote more and more women going out there to do their mammograms. So I do believe we can talk about statistics and numbers all we want, but we know one thing for a fact. Again, I'll reiterate it. Early I find it, the better I can treat it and cure it.
So that's very interesting statement of the curing. And so I know there's been recently, over the last couple of years, there's been a lot of press about the latest, you know, protocols involving mammography. What's the first age you should get it? What's your baseline? How often should you be doing this? Because with all of this awareness, how, I think there's a lot of now misinformation. So what is the real story? What are we supposed to be doing?
So the one statement I make to every patient, your biggest risk of breast cancer is being a woman. That is it. We can all talk about family history, risk factors, but being a woman is probably your highest risk. The second highest risk is probably aging. Current guidelines, they're different kinds depending on what message you read. But American Cancer Society, as well as the American Society of Breast Surgeons, all have put together and come up with sort of a consensus, you can call it. And my consensus is, after so many years of doing this and so much cancer that I treat and see every day, that for an average risk woman, average means every woman at the age of 25 should be seeing their primary care or the gynecologist to assess risk. What is my risk for getting a breast cancer? And there are certain calculators out there that the primary care use, and I certainly do in my office as well, that figures out risk. So if you're an average risk woman, I think starting annual mammography at age 40 is very reasonable. And annual, I do mean every year. If the breasts are not dense, that is, the x-ray is easy enough to read for the radiologist, then that should be the only test you need for now, unless you get a problem. If they are dense, however, that is, the mammography is harder to read and interpret for the radiologist, we do sometimes add screening breast ultrasound to that. And that can see through some of that dense tissue and helps us get a better idea of what's going on with the breast at that moment. So I would say starting at age 40 starting at 25 for risk assessment, starting at age 40 for an average mammogram. If a woman is considered to be high risk, we typically like to start mammography 10 years before the youngest relative. And that's sort of doing a lot of math, but let's say your youngest would happen to be 40 in your family, an aunt or a mother or someone, you should actually get your screening mammogram at 30 as your baseline.
Okay, that's very interesting. Because I've never heard that before. And
Yes.
Obviously you said being a woman is one thing, age is another. Can you talk a little bit about the genetic impact? Obviously starting 10 years before a close relative, but
yes.
And interestingly too, I do want to bring men into the conversation, which we will get to
Absolutely.
in a little bit. Yeah.
So genetics. So we all want to talk about genetics. BRCA is all out there. It's a lot of women are now pretty savvy about knowing those words even, but just realize that genetic breast cancer is still the small number. But it's important to do that risk assessment, I think, is really the way to figure it out. And yes, I was going to get into whether there's genetic breast cancer, there's hereditary breast cancer. And again, the greatest risk is neither one of those. Being a woman is the highest risk.
So that's an interesting term you just used. Genetic breast cancer versus hereditary breast cancer. Right. Can you just kind of give us what that difference is?
So there's certain genes we know of that elevate our risk for breast cancer. Maybe about 10 of them or so that we know of. Maybe there are others out there, but there's certain families I follow, the daughter, the mother, the grandmother, and and they've all had a problem. And there's something there, but I can't find a gene that tells me that this is the reason why they're all getting breast cancer in that family. So I then put it into the category of hereditary breast cancer, that there's something in that family that prones them to getting a breast cancer for whatever reason. And I don't think we have a reason yet.
So that hasn't been proven genetic.
Correct. Okay. Exactly.
All right. So the number 1 in 8 women who present with breast cancer, is that still the number?
Unfortunately, we have not done anything better than that. Yeah, as far as finding breast cancer, and 1 in 8 will get breast cancer, correct, in their lifetime.
Okay, so when you look at that, is that a function of early detection now that everyone is going? What are the current stats for detection and longevity and survival through this? Have any of those numbers changed?
So 1 in 8 has been pretty steady for a while, since I've been giving these talks for 22 years now. But I do think that our detection rate is definitely increased every year. We do find more simply because of more women doing mammograms, I feel. I would love to get more because I do think that the key thing, again, I'll reiterate, is the earlier I can find it, the earlier I can treat it and let it be less of an effect on a woman's life. The statistics speak for themselves pretty much that stage 0 breast cancer or stage 1, which is a very early breast cancer, the survival over 20 years after diagnosis is almost 90%.
Wow.
Versus something that presents at stage 2 or 3 or 4, certainly, the numbers go further and further and further down. So we do know that survival is improved with earlier we find it. And our biggest tool for that is a mammogram.
Okay. Can you talk a little bit about what the different types of mammogram are? Because I know there's a screening one and then there's a diagnostic one, and there are also different machines. And I know at St. John's we have a 3D, which 3D. Is a tomography. Can you talk a little bit about that so that so our patients in our community know what is sort of the leading edge stuff that they should be thinking about?
Absolutely. So it's a great question because there's a lot of confusion about that as well as to what kind of mammogram should I have? Should I have a 3D mammogram? So years ago, when I started practice 22 years ago, we only had what's called analog mammography, which is, I don't know if you remember when photographs were taken and the film had to be printed out, and now the digital pictures look so much prettier. It's the same thing with mammography. We've now been doing digital mammography. I don't think there's any place in Westchester that does analog mammogram for the past at least 10 years or more. So digital mammogram has just was a little bit of an annoyance initially because we started comparing apples to oranges. We can see so much more on a digital mammogram versus an analog mammogram, just like film, just like a photograph that you might take. And then came on the advent of 3D mammography, which the hope was that in the some women who have challenging mammograms to read for the radiologist, we would have to do like 10, 12 pictures of each breast for different reasons, trying to find things. And with the advent of 3D mammography, we've been able to go away from that, where we don't have to do as many pictures. So though 3D mammography has a tiny bit extra radiation compared to digital mammogram, we do feel that there's value to that, particularly in women who have dense breasts, who have mammograms that are difficult to read, who for some reason or the other get extra pictures. We actually, I think, end up better with doing a 3D than someone who does not or gets digital mammogram. So that's one place where 3D mammography is very, very useful, certainly. And the younger you are, the more dense the tissue usually, and those are the women we want to steer them towards having a 3D mammogram. Now, yeah, hope that helps.
So at St. John's, what's the what is that called now?
So that 3D mammography is also called tomography. That's the same sort of word. Yeah, we also have something called CAD, which may be a word you may read, which is a computer-aided read of the picture, but we still have a radiologist read them. And yes, we have digital mammogram in addition with the 3D component in both our locations at St. John's.
Okay, so let's go from the diagnostic piece, which is what that is, to the treatment. So you now have a patient in front of you who has been diagnosed with, there's something seen. What are the new treatments? Because I know there's a lot of money that goes into research, and there are three things I want to bring up: the medical treatments, the radiation treatments, and the surgical treatments. So if we could start with the medical treatments, what is new and happening?
Sure. I'll just say one little blurb before I continue on that question, because I want women to understand this, where if an abnormality is seen on a mammogram or an ultrasound or something that your doctor feels, once we do the appropriate testing, the next step is a non-invasive needle biopsy of that lesion. That's how we make a diagnosis these days for the past 30 years now. Years ago, we used to have to take out the lesion to make a diagnosis, which was a surgical biopsy. We thankfully don't have to do that anymore. So, that's one of the fears that women have. They don't want scars on their breasts. But certainly to make a diagnosis, you do not need to do that. But yes, once the diagnosis of a cancer is made, the first step is usually seeing a surgeon. And the surgeon will go over your entire history, your family history, see if additional testing is needed. If not, then most women, the first step is surgery. So we'll talk about all of these, but I'm just sort of want to walk them through what they would go through in a surgeon's office, where a history is taken, exam is done, and then we sit up, and if additional testing is done, that's completed by the surgeon as well most of the time. And then depending on what the surgeon feels, how advanced they feel this scenario is clinically, looking at imaging, looking at the exam, that's when we decide, okay, that surgery is needed. In surgery world, breast conservation, or not having to take the whole breast, doing just called a lumpectomy, has been around for over 30 years. I've been doing it myself for 30 years. So certainly that is not anything new. What's new in surgery field is we can do less and less lymph node surgery, which is an awesome thing for us, because years ago when women had their lymph nodes removed, they would have problems with a swollen arm. They were told, don't get blood pressure cuffs here, don't get IVs here, don't get your blood draws here. Now, because we only take a few of the lymph nodes, all of those things have been not as important to us. So I think we can do less lymph node surgery. Breast-wise, the choices are usually pretty much the same it's been for a while: lumpectomy or mastectomy, which is taking the breast.
So can you just talk a little bit more about the lymph nodes? There's a mapping thing that you do. Can you talk a little bit about that?
Sure. So there's a technique called a sentinel lymph node biopsy, which has been around, again, 30 years at this point. I started in 95, I think was the first time I ever did it, maybe 96. What that involves is injecting 2 dyes into the breast the day of surgery. And that helps me find one of the first few draining lymph nodes from the cancer, which is under the arm, is where we usually go looking for these. And any lymph node that looks blue because of the dye, or hot because of the radioactive material that's injected into the breast, those are removed. That doesn't tell me whether the lymph node is positive for cancer or negative for cancer. It just tells me these are the lymph nodes draining the cancer. You don't need to remove all the others. Just take these out. Let's test those. If those are okay, then I don't need to go back and do anything more with the lymph nodes.
Okay. And if they do show cancer, then you have to go back and do something.
Not always. That's
okay.
That's the really newest and the greatest, is that not always. If it's just one lymph node, for example, out of several that I happen to take out, then I may not need to go back. It depends on a lot of different factors I can't get into: age, how aggressive we feel the disease is, go on and on and on. But not every case. Very rarely nowadays do I go back to do lymph node surgery.
Okay. That's a very interesting.
Yeah.
Okay, that's a very interesting point that you just made, which is that the aggressiveness of the cancer. There are different types of breast cancers. Can you just speak to what the differences are? Because I know, my mom is a survivor, and her form was quite aggressive, but it was caught extremely early. Okay. So how give us a little something about that.
Sure, absolutely. So as far as types of breast cancer, most of the time there's actually only 2 kinds in the world. 90% of breast cancer comes from the ducts in the breast. 10% comes from the glands in the breast. So that's not what tells me the aggressive nature of the disease. What tells me the aggressive nature of the disease is 3 biological markers that we test on the tumor when we do the needle biopsy, and the pathologist will tell me how aggressive the tumor looks under the microscope to them, and grading it from 1 to 3, 1 being the most aggressive, 3 being the most aggressive, 1 being the least aggressive. And we look at these proteins that sit on the cell surface, not to give anybody a biology lesson, called an estrogen receptor, a progesterone receptor, something called HER2/neu. Those are 3 things that help us guide treatment, and also tells us how aggressive this disease is. And that's how we can base our surgery, our medical oncology opinions, as well as our radiation oncology opinions.
Okay, that's very interesting. So you start with the surgical oncologist, and then you make a determination of the kind of surgery that you're going to do, whether it's a lumpectomy. I know fewer and fewer mastectomies are being performed, but are they still an option? And
absolutely, it's always an option for women. It's an operation that works well, and we always follow that with a plastic surgery consultation to talk about reconstruction options, which we have several different kinds now. Certainly, so absolutely, it's truly, there's still some women who, even though I say that you can do just as well with a lumpectomy and radiation, which is pretty much always given after lumpectomy in women less than 70, because that's how we get to as good as having a mastectomy as far as the chances of this coming back and survival. But yes, there are women that can absolutely choose mastectomy. There's certain clinical scenarios where I say that's really the best thing for you. And that's when and if they're trying to make a choice, I have to meet with the plastic surgeon anyway to see if that helps them decide whether I should do one or the other based on what reconstruction is going to be like.
Right. So once that decision is made and a surgery happens, let's talk about the kinds of treatments that are, obviously people know chemotherapy, they do understand there's radiation, but, and you can talk please a little bit about those, but there are other things that are kind of out there, and maybe we can address like immunotherapy and things like that.
Yeah, so again, it all depends on a lot of different factors, of course. You know, how early did we find the cancer? What were those 3 markers that we talked about? How old is the patient? What is their medical condition? I mean, all of that, the next step after I feel like the surgery is done, and goal of surgery, of course, is to remove all disease, is then when I send them to the medical oncologist to St. John's for an opinion to figure out what would be the next best step for this particular patient. Sometimes it's just a pill a day. Sometimes it's aggressive chemotherapy. Sometimes you're right, it could just be immune therapy. So it kind of depends on the scenario. Each patient is sort of different. Unfortunately, I wish I could give you a general consensus, but I don't really have one. But what we do have, which is amazing, is something called a recurrence score, which we do use in our practice here, me and the medical oncologist, more the medical oncologist than for me, where what is a recurrence score? And the most common one used, which we use at St. John's, is called an oncotype. What that basically is a test that's done out in California, and they look at all the genes that the tumor from the patient is expressing. That's done on the surgical specimen, and they compare it to known genes, and they have an idea of, if you have these genes in the tumor, what's the chances this tumor is going to come back? So years ago, we used to get stumped where it looked like a very early cancer, looked like a good-looking cancer if there is such a thing, and yet 2 years later, the cancer would recur. So we couldn't understand. Same thing the other way around, where something looks really aggressive, but may not be as aggressive as we think it is. So this recurrence score has really guided us to figure out, maybe there's some women we don't have to give chemotherapy, but we're fine with just the pill. And also guided us the other way, where some that looked like they should be nothing are more aggressive than we think. So maybe these other kind of women we should be offering more chemotherapy to. So that's the most amazing thing in my mind in medical oncology world that's been going on now for the past 10 years. But yeah.
That actually, I didn't really understand that and didn't know that was a thing. I'm really pleased to hear that, because I have to imagine that when you have someone sitting in front of you, and I know women, and we've been through this in my family, when you have a plan and you have confidence in the players in the scene, then you know that you feel there's confidence. But that kind of an ability to score something like that, it sort of adds to that level of being comfortable, which I think is a really great thing.
Absolutely.
All right, so let's talk, and I mentioned this before, men do get breast cancer. And I know October is all about celebrating women and survival and beating it and curing it. But what about men?
Absolutely. Actually, for whatever chance, I've had 3 men in the last 3 years that I've diagnosed with breast cancer. So yes, it's a very important thing. So if, let's say, there are about new cancers this year in women will be, the total number of breast cancers in this country will be about 300,000. Out of that, 1% will be men, which is about 3,000. So it's not a small number. Men do get, unfortunately, they don't get screening, which is fine. There's certain ones we do screen more actively if there's a genetic mutation in the family, but that's a pretty rare event. Most of the time, men present to their PCP saying, my chest is itchy or hurting, or, I feel something there because I happen to feel it in the shower. Generally, men get diagnosed at a later stage than women do, again, because there's not enough vigilant testing going on. All the 3 men that I can tell you about that I diagnosed in the last 3 years, none of them had a genetic mutation. Though if you have a family member who had breast cancer and is a man, they are at an increased risk of having a genetic mutation. So they're the kind of families we do want to test. But in this particular scenario, neither one of them did. But yes, men do need to be careful about their chest. Anything new you feel, whether it's pain, whether it's a lump, whether it's a rash, whether it's itchiness that doesn't go away, I think it's on you to sort of go back to your PCP saying, hey, I'm feeling I mean, I do see about 1 or 2 men a month for something or the other. So our community of doctors is pretty savvy about this, I feel. But I think men themselves can be a little bit more vigilant as well. Yeah.
So I do think that's very interesting because I don't think it occurs to most men that this is something.
Yeah.
So there is a real need then for some awareness. Now, I didn't quite follow the genetic piece of that. If a man had a mother who had breast cancer or an aunt who had breast cancer, is there the ability for him to be genetically linked to that breast cancer?
Only if the mother was positive, then certainly the son can get tested as well, because unfortunately it's not just breast, there's also risk of prostate cancer, pancreatic cancer that's linked to those same genes as breast.
Okay.
So if
All
you had a
right.
mother with a BRCA mutation or any one of those other mutations, there's 10 other ones, certainly you can also ask your doctor to be tested, absolutely.
Okay, so that's interesting that the breast and prostate, those are all connected to the same genes?
Yes, in some cases, yes.
Okay, that's very interesting. All right, well, we've covered a lot of things, but I want to ask this because we're all being so bombarded with information. We are
Yeah.
all, between social media and the news and everywhere you look, it almost feels competitive information, like do this or do
So
that.
true.
Aside from having genetic screening, when you know that there's maybe a family link, or your mother had it, your aunt had it, your sister had it, maybe you should be tested. What are the things that people can do for prevention? What is the real
Right.
story here?
So, every year when I go to my breast surgery meeting, we as surgeons all discuss this. We talk about it. There's usually some talk by some nutritionist or alternative medicine person who gives us a talk. And, the two things that I hear every year is, most of these things are known because it keeps away most kinds of cancer: a high fiber diet, low fat, and most important one that's coming up even more and more is moving. Our lives have become sitting in a chair a lot, and as we all know. So our belief is that the more you move, the less chances of cancer. And the numbers we've thrown around for breast certainly is about an hour and a half a week. It doesn't sound like a lot, but you'll be amazed the number of patients I talk to about that, like, oh, I can't do that, I'm too tired after work. 10 minutes of walking outside, 10 minutes of walking outside, or some kind of movement is really what's needed. And certainly, sticking to a good diet, keeping your normal weight, all of those things. And there's certain risk factors we can't control. We can't control when we started menstruating, where we can't control whether we have children or not, because not having children is also a risk factor. Breastfeeding helps actually not get breast cancer. But again, some things we can't control, but the things we can possibly control is diet, exercise, small link to perhaps smoking as well, but there are lots of other cancers that certainly can be prevented from not smoking. But two important ones I would say is diet and moving.
Interesting. So all in all, although the 1 in 8 statistic is still sort of hanging around, you feel that with the recognition that we go through every October, the prevention, the messaging, everything that goes on, do you think it is impacting the community and your patients and our patients for the better?
Absolutely, because I could tell you my busiest month is usually December, January, because
Oh,
women go for their mammograms in October.
yes, they do.
X number do. I mean, even with Christmas, I'm busiest in December and January. So if they do the
Wow.
mammogram, yes, more things possibly will be found, but then you're being proactive about your health. That's how I think women should view this. It's nerve-wracking. I mean, I still see the gamut of patients. Only a few months ago, I saw one who literally had this big tumor in her breast that was making a hole in her breast, and she just didn't want to go see anybody. It was a year. She just sat like that. So there's fear. There's a lot of fear out there, and all we can do to alleviate the fear is say you're being proactive about your health. I mean, it's not easy. I get that, and it's not easy to say I want to go get squished today, but it really can make a difference, I believe.
It can make a difference. So annually after 40, unless there's a genetic
Unless
situation
there's,
going on,
or
right?
just an increased risk in general, may not be genetic necessarily.
Okay. Do you think environment is playing a role in what people are presenting with when
Oh,
there's no
I
genetic?
absolutely believe that. And so the cancer cells have a way of repairing, no, not cancer cells. Our normal cells have a way of repairing ourselves. Our DNA repairs itself every day. And we do believe that there's a genetic, there's some kind of DNA mechanism, repair mechanism that's going haywire. And what in the environment causes that? There's some communities like Suffolk and up north here who did studies, looked at hair samples and water samples, and nothing ever actually panned out. But it probably is something genetic, something in our food, something that's, there's not as much cancer on the eastern part of the world. So it tends to be a disease of people who are not developing countries.
So do you think that the sedentary discussion, being sedentary, is maybe a bigger factor? Because in the developing countries, people still are more mobile physically.
Yes, exactly. I do think that. I mean, and I think we're going to unfortunately possibly see it even worse, because given with COVID, people are working from home. They're just sitting on their desk. They're not even moving to take public transportation or their car. Well, we'll find out. But I hope I tell everyone, get up and walk around for 2 minutes before you go and sit down again. That's what I tell my patients usually. Do some form of meditation. I'm a believer of that as well. Some kind of all the mental angst around us and the world going on, to keep your mind sort of in the game.
Yeah, and do you think that there is something about sort of the way we live with stress? You think stress might be a factor in this conversation?
Absolutely.
Oh,
We know that stress decreases our immune system. That's a known thing. And you wonder if decreased immune system could equate to some repair mechanisms that don't work quite as well. I mean, this is all just hearsay and just from reading a lot, but I can't say that I have actual data to say that. But that's where the meditation part comes in. The lovely YouTube videos. I tell my patients about them all the time.
Okay. Is there anything else that that we didn't cover that you think we should be talking about today?
I think the two things we didn't touch on, which I rather we can talk about breast MRI, because we do have that at St. John's as well.
That's great.
And sometimes women ask me questions about, should I be doing an MRI? Should I be doing something more than a mammogram and an ultrasound? Breast MRI, I started this again when I was a fellow in California, and we did a lot of them. And when I moved to New York, we did a lot of them. But we found over time that though it's a very sensitive test, it's not as specific to. It lights up a lot of things that causes a lot of anxiety in a lot of people. So it really has to be done on the right setting. So the settings we typically use breast MRIs, women at high risk, because now we're accepting the fact that she may get an extra biopsy because something is going to be found.
Right.
Or in women that I feel, once I diagnose a breast cancer, that I feel I need to do one to make sure there's nothing else going on. Those are the usual, most typical scenarios that I use it in. But we do have that at St. John's as well. So
we do, and I know there's a breast coil with the one that's at our Dobbs Ferry Pavilion. Yes. I do want to talk a little bit about the services that we have at St. John's, because we have an incredible department for mammography and breast ultrasound, and as you said, we do have the breast MRI available as well, and we have also, by the way, and she's actually done a webinar for us as well that we put out there during this month, but Sherry Rosenberg, who is our patient navigator, is just the most wonderful resource. And I mean, for things that have occurred, and even in my own life, and she's a hand holder for sure. She makes the appointments, she gets the resources, she moves you through the system. Everything sort of comes into, and I kind of wanted to give her a plug because she's amazing. So for all of our friends out in the community, I ask that they call. So with that, I would like to thank you for spending this time with us, and we'll be putting this out on social media. So for all of the people who are attending, if your friends have not seen this or couldn't get on today, it will be on the social media channels of St. John's tonight, and it will run and be out there. So let's go to some information about Dr. Sahgal. If anyone would like to call her office, she is located not far from the hospital, just across the street a little bit, and her number is 914-965-2026. And going back to our mammography suites, we have one here in the Andrews Pavilion on North Broadway. call for your appointment. You can also, by the way, request an appointment online at riversidehealth.org, and that's right on the homepage. You can just press the button, fill in the form, and they'll get right back to you. And that number, if you want to call Central Scheduling, is 964-4329. The Dobbs Ferry office for mammography is 693-5025. And Sherry Rosenberg, whom I mentioned before for our patient navigator, is at 964-4327. If you missed these numbers and would like to send me an email at info@riversidehealth.org, I'm happy to give you that information via email. For those of you who are experiencing things but still have some concern about venturing forth or going into a doctor's office, please feel free to call for virtual urgent care, and that number is 914-207-0006, and they will make an appointment for you. Again, info@riversidehealth.org if you have questions, if you need that information sent to you. And by the way, if you want to go through physician referral, that number is 914-964-4DOC. That's 4362. New to us is our Spanish line for physician referral, and that number is 914-964-4245. So with that, Dr. Sahgal, I thank you so much for your time. I know this is a busy month for you, and we really appreciate you.
Absolutely. Very important.
Thank you. And thank everyone for attending today. Have a great day, everyone.
Take care.